There we go. We're good to go.
Terrific. Thank you, Patrick. Good afternoon, everyone. My name is Raelynn Douglas. I'm the CEO of Raesoleil Consulting, and I'm so excited to bring you our first LinkedIn Live event here this week. Hopefully, there's no technology challenges like we experienced last week.
Mhm.
So, thank you so much for joining us. We decided to create this opportunity to bring healthcare leaders together to talk about the health human resource crisis. And we've entitled it Let's Get Real, because we feel that we need to talk to people who are on the front lines in leadership positions or on frontline care to find out what exactly is going on with our health human resources and how can we move to solutions for this crisis. So my name is Raelynn Douglas. As I mentioned, I'm going to introduce my panel that I'm joined with here today, and then we're going to move right into the conversation. I'm joined by Suzanne Schell, CEO of the ROI Institute of Canada. And ROI, for those of you who don't know, is return on investment. Suzanne is Canada's leading expert on the ROI methodology. She has a passion for healthcare and has helped hundreds of organizations in the US and Canada by building capability for this unique leadership competency, helping organizations make the smartest investments with their scarce resources. When I learned of Suzanne and the ROI methodology, I was struck that this is exactly the skill set we need in healthcare leaders to be able to demonstrate the ROI when the CFO asks you to show me the money. Next, Dr. Paul Woods is the Chief Strategy Officer of Caring Support and the former CEO of the London Health Sciences Centre, and that's London, Ontario, for those of you who don't live in Canada. Dr. Woods is a family physician who's been an innovator and a disruptor in the healthcare space for a long time. I first met Dr. Woods when he was a keynote speaker at a conference about virtual care several years ago, long before COVID made virtual care a more common practice. So, as you can see, Dr. Woods has become an expert in both the Canadian and US healthcare systems and offers strategic guidance to Caring Support now, an equally innovative healthcare professional recruitment agency. Dr. Woods understands the huge financial impact of employee churn and has some insights for us into how we can find solutions to the health human resource crisis. Patrick Thiele and I realized we share a common experience. We both served in the Saskatchewan government, he in the Ministry of Justice and me at Finance. After Saskatchewan, I moved to the wonderful location of Guelph, Ontario, while Patrick made the more glamorous choice of moving to Guadalajara, Mexico to open a hotel. So no doubt he offers a different lens to his role as Chief Operating Officer at Applichat Healthcare, informed by his experience in government and the hospitality industry. Like our two other speakers, Patrick has an extensive knowledge of the US and Canadian healthcare systems, given that his clients serve in both those countries. And while his organization, Applichat, focuses on recruitment of nurses, we felt his insight and perspective would definitely enhance our conversation today. So a quick comment on my background: Ministry of Finance for many, many years, and then moved to Ontario and worked in home and community care as a director of contracts with the Central West LHIN. I became very curious in my Rotman MBA and decided to get busy finding solutions to this crisis. So when Suzanne and I met in 2020, I said, let's get together and partner on this crisis. And as we meet with healthcare leaders, we're amazed at how few of them know the turnover rate for their organization, nor have they calculated the huge cost to replace those valuable healthcare staff. So we hold the belief that millions of dollars could be redirected back into the healthcare system if we placed priority on retention as well as recruitment as part of our people strategy. So today we're going to talk about R&R, recruitment and retention. And like any good program evaluation, we'd like to start with why. So our first question for the panel: why are people leaving healthcare? And Paul, if you don't mind, I'd like to start with you.
Rule number one, come off mute. And I managed to navigate that one just fine. So we're going to be good. Yeah, thanks, Raelynn. Thanks for the introduction. And thank you to everybody who's participating on this. And hopefully together we can find some solutions. I think that, I started in healthcare and med school in the early 80s. Graduated in the mid 80s, and it was obvious to me that there was a vulnerability that was demographic, and I think it's even more so right now, where you have two sort of modes, very dense population groups in healthcare and some of the frontline professions, particularly the nursing professions. So people more in my demographic, around 60, mid 50s and onwards, and then some very young. And if you think about who might be more inclined to leave the profession, one group would be those that are really close to retirement and can retire. They have a pension, even if it means they're not going to have quite as much as they want. And then the second is people who haven't really invested a number of years yet. And so those would be the nurses in their 20s and in their 30s, and other healthcare workers as well, not just nurses. So I think there's a sort of a setup for a bad situation when you have an industry like this one, which is starting to unravel. The second thing is healthcare always has been and always will be a hard industry. People who go into it, I don't think are going into it expecting that it's just going to be these quiet days of putting in your 9 to 5. There's always an element of adrenaline and chaos, regardless of which setting that you work in, but the closer you get to the front line, definitely more. And so it's a tough industry to begin with. The third thing is we have been talking about burnout since long before the pandemic. A big study that was done by the Proceedings of the Mayo Clinic about 6 or 7 years ago that was showing really shocking numbers in physicians of about 50% were showing signs of burnout, which is a shocking statistic, but it was actually worse in nurses. It was somewhere in the 60%. So this is long before COVID either existed or was recognized to exist. We had a setup where people were burnt out and tired. Then we went into a global pandemic and all hell broke loose. And I think that, there are a whole bunch of factors. I think that the work has been much more frantic. We knew that nurses who were on the front line during SARS in Toronto were far more likely to suffer from post-traumatic stress disorder. And this, of course, has been worse than that. So I think that we're taking a burnout workforce and now making them even more so because of the pandemic. And I think there's a last person out, shut out the lights kind of thing. As you start to watch the workforce and your colleagues leave, go somewhere else, go out on stress leave, it puts more on you. There's more mandatory overtime and all those sort of things. And I think that, I think that the pandemic has just been gasoline on the fire. I think the final thing is, I was actually a patient in London Health Sciences early in the pandemic, in the first wave. And I looked up at the Delta Hotel in downtown London, and it had in the windows, it had this was at night, it had lights on, and it said, "We heart our healthcare heroes." And, we had people that were volunteering to drive by with food and cards, and there were drive-bys and everything like that for about the first 6 or 8 months. And then it started to get mean. And so we had these healthcare workers who were putting it out on the front line. They were tired. They were risking their own lives. We couldn't get enough personal protective equipment in those early days. And they didn't know whether they were going to die as a result of their job. They were staying away from their families to avoid protecting them. And then you have people outside the hospital or outside the healthcare facility, no matter what it was, that are picketing and that are threatening violence in the hospital. I have a daughter who's a nurse here in the United States, and she had a family threaten her because their family member was dying of COVID, and COVID isn't real, and therefore the hospital was lying to her. And so it's like, why would you stay when you're putting it out there? You can't be protected by the system because there's not enough PPE. And then the people that is the only real reason why you're there are angry at you, taking out mask mandates and vaccine mandates. So this shouldn't be a surprise to any of us. And sorry for that PhD dissertation.
Excellent. Great insights. Patrick, would you like to share?
Sure. Yeah. Thanks, Raelynn. And nice to be with all of you to talk about this today. Hi to everyone who's watching. Paul did a great overview. I ticked off a lot of things on my list as he was speaking. Definitely, obviously, when we speak to healthcare organizations in the US and Canada about their, we focus mainly on nurses, but about their nurse recruitment needs, they are definitely saying that nurses have left because of burnout due to COVID, health and safety concerns, where all the things that he mentioned, and the sort of the politics come into it between coworkers, with management and with patients, has been a big issue as well, that are driving people away from healthcare. Of course, some folks have been leaving healthcare in order to care for a family member as well. That's the other thing that we hear quite often. And in addition to people leaving healthcare, we know that a lot of nurses, everyone in healthcare, all roles, are leaving their roles for other healthcare organizations. So we're seeing so much movement within the healthcare industry across organizations. And if a nurse or someone else working in healthcare is tolerating something, they're putting up with something about the workplace culture, their management, and so on, or health and safety issue there, maybe it's money, right? Then if they see a better opportunity, or what they think is a better opportunity, they're probably going to go, or they're much more inclined to go than they were even 2 years ago. So that's a factor as well. So not only the folks that have left healthcare, and hopefully some are coming back, but also the people that are willing to move and give up their existing employer to go work somewhere else.
Great insights. Thank you, Patrick. And Suzanne, over to you. Oh, you're on mute. Had to get that in there, one of these.
Sorry, we're not pros at this. Wow, it's so nice to be sitting here with the three of you and listening to Paul and Patrick from the roots of the problem, share the reasons why people are leaving healthcare. I come from a different perspective with my ROI hat, return on investment hat on, and all the work I do in healthcare. I certainly know and hear from all the experts, and these two as well, and Raelynn, burnout, we hear that all the time. I'll speak to that in another question, my opinion on burnout. But why people are leaving healthcare, I think it's just an environment that's become so, I'll use the word toxic, that they're searching for a better place to spend their 8 to 12 hours a day. I really do believe that. I don't think it's money, and I've been told by many experts and leaders in healthcare in Canada, we can't fix this problem by throwing money at it. So it's just stepping back and looking at what this toxic environment is doing to cause people to want to go to a better place, go where the grass is greener. And as Patrick said, they think it might be better. They're willing to go search it out.
Terrific, and I think that draws back to one of the comments that was made on LinkedIn after we first announced this conversation we were going to have. Somebody said, "Listen to the front line," because we don't know exactly, in leadership positions, what exactly is happening. And Paul, that's so interesting that you had that perspective as a patient as well during COVID. So, and with your daughter being a nurse, so very astute comments from all of you. I just wanted to comment too on burnout. With the World Health Organization identified burnout in 2019 as an occupational phenomenon back, before COVID. And the three things that identify burnout are feelings of energy depletion or exhaustion, increased mental distance from one's job or feeling negative or cynical, and the third one is reduced personal efficacy. So that's a classic WHO definition for it. And I think what excites me a little bit about that is that it's not just about the individual, it's about the workplace. It's an occupational phenomenon. It's not just stress, it's about something in the workplace. So there's an opportunity for us to have an impact on that. So I'm excited to move into the next sets of questions. And I see there are a couple of questions coming in from the chat, which I will not lose. I hear one from Jay Porter about housing. So we'll come back to that if you don't mind, Mr. and Mrs. Porter. And so our next question, as we look across the healthcare system, initially we were saying Canadian, but obviously Paul and Patrick bring a unique North American perspective. Not many people or governments or organizations are focusing on retention. Would you agree with that statement? And maybe Suzanne, we'll start with you.
Well, yeah, I do agree with it. And even prior to my partnering up with Raelynn on tackling this HHR crises, I would see and hear Lots and lots of talk about recruitment, lots and lots of recruitment strategies, money, bonuses, and we're hearing it all the time, even like today, yesterday, all the work that leaders in healthcare organizations are doing to recruit. But nobody is talking about retention. We don't see that in the headlines. We don't see organizations are doing A, B, and C to ensure they're keeping these valuable people in their organizations. We can't have a quality healthcare system without those people. So losing them is a cost to the system, and it also decreases the quality, and they need to be talking about it. And finding out their turnover rate, someone will be shocked to know that. And then that rate converted to a monetary value to show you the amount of money that's going out the window because we keep losing people and having to recruit. So yeah, we need to talk about it. And I listen to the news. We all do. And we hear lots and lots of recruitment strategies out there across Canada and in the USA, but nobody's talking about retention. And I think I have another reason for that too that I'll speak to in another question.
Excellent. Thank you, Suzanne. Paul, do you want to jump in there?
Sure. Yeah, I think Suzanne nailed it. I think that nobody wins when a person comes to an organization and leaves, whether it's in 1 or 3 or 5 years. And sometimes it's a life thing, like family issues or something like that. But, there's the monetary implications of it. And Canadian hospitals and Canadian healthcare institutions live on a very thin sort of margin, if any margin whatsoever. So there's a financial one, but there's also a huge people cost to it, whether it's the healthcare worker themselves who, say in a city like London, where there are 2 hospitals, do they go to a different sector like long-term care or home care? Do they have to leave the city and that sort of thing? So I think that there are really big implications for both the institutions financially, culturally as well. If you're constantly changing your people, how do you ever build that sort of teamism and esprit de corps and that sort of thing, but also to the healthcare worker themselves. I don't believe that the focus on retention has been anywhere near what it is on recruitment. I think there are initiatives that people do, and I have to give Susan Nicol, who was our Chief People Officer at LHSC, credit for trying to bring in things like Just Culture and sort of cultural programs that tried to help people to feel that the organization treated them fairly and sort of that kind of thing. But I would say that the relative proportion of effort and resources on recruitment versus retention is 90-10 or worse, and needs to, obvious for all the reasons we've talked about, be different from that.
Excellent. Thank you, Paul. And Patrick, to you.
Sure. Yeah, I agree. Definitely most organizations are definitely spending more time thinking about recruitment. When I talk to healthcare organizations, of course, that's most of my focus, because that's the business we're in, is to help organizations recruit nurses. But when I ask them what they're doing in terms of filling those vacancies, they have a million things on their list of what they're doing to recruit, and sometimes they mention things they're doing to retain. So I would agree with you, with the others, that definitely retention's usually a bit at the back end in terms of consideration, but I see it growing. So we've recently at Applichat, we've done a couple webinars. We've expanded out our topics beyond nurse recruitment, and we've talked about implementing employee referral programs and recruiting boomerang nurses who've left the organization and maybe can come back to your organization. And we found a lot of interest in that. So we've got a lot of attention, and we've had a wide range of responses. So we've had organizations saying, yep, we're already doing it, or we're doing it and we think we need to improve it because we need to get better results. And of course, we've had some that are saying, we haven't done anything on this when we really need to start thinking about it. So it's really interesting to see the range of responses. So I hope that's improving as organizations are thinking about recruitment. They're also thinking about retention. I just think it's almost easier, maybe human nature, for us to think concretely about why someone would want to come to your organization than to step back and look at your existing team and think about why someone would want to stay. I think people can describe it more easily, it seems to me. That's my observation. So I guess I encourage organizations to think about it, to step back and think about it a little bit more broadly. And one of the things we do around this is to remind recruiters the impact they have on the workplace, including on retention, with the dollar spend and the dollars lost if they have vacancies. You both talk about, Suzanne and Raelynn talk about return on investment. So that's important. But usually we find recruiters and people in HR really don't understand in much detail the impact of having a vacancy in the organization. So we find that that's helpful to get them thinking about both recruitment and retention efforts.
Raelynn, can I just jump in? I just want to follow up with some of what Patrick said with how would it be in an interview or a recruitment process if the person being interviewed for a position asked the organization, what are you going to do to retain me? What's in the works here to ensure I stay here? So those are kind of cool questions that I talk to healthcare people about with this problem.
Yeah, and I think as we have our conversations, great point, Suzanne, we often say, if you designed any conversation or program or policy or anything with the goal of retention, you'd have a very different set of questions or outcomes, because most of these conversations about performance management or getting rid of or dismissal or punishment. But if everyone had, number one, their goal as retention, every conversation would be different. And just going back to Patrick, your comment about human resource professionals don't necessarily think this way. That's the mission that Suzanne and I are on, is to have finance people think like HR and HR talk like finance, so that we can break down those silos and say there is huge value in investing in our people. There is great time and energy spent on a new onboarding process or a new recruitment process that has retention as the goal. And we can show you the money on how those initiatives drop your turnover rate and reinvest that money back into your system. I think it's so amazing to us how most of the leaders we speak to have never calculated the cost of turnover or replacement, and both the direct and indirect costs are massive. So now we get to talk a little. Oh, sorry, Paul, you want to?
I just wanted to add a point on one of the things that we're seeing down here, and I know in the U.S., and I know a lot of people have talked about in Canada, has been sign-on bonus and retention bonus. The problem is everybody's doing it now, so all it does is re-level the field again. So if the sign-on bonus to go down the street is 20,000, retention bonus is 20,000, it's exactly as if nobody paid a bonus, other than the person has 20 grand more in their pocket than they did before. But ultimately, that's a zero-sum game, and people can't just keep escalating that. Nobody can afford that on either side of the border. So those kind of things, what we're talking about, I think, is far more important, which is about cultural elements, giving people meaning in their work, having a sense of belonging, just culture, et cetera, far more than retention bonuses.
You're sneaking into the third question there with your commentary, which is wonderful. But just one comment on what you said just there. The other thing that's not sustainable is the agency nursing reality that we're all facing. Obviously, we need staff vacancies filled, and we need people on the floor, so we turn to agency nursing, but it's becoming more and more expensive. And I think for me, the aha moment when I did my MBA study was, we've been dealing with this COVID level crisis in home and community care, which is where I focus my attention, for decades, and it's no wonder it's not sustainable. We're wasting so much money on churn, and those are expenses we have to have interviews. We have to have, hire an agency like Applichat or Caring Support to get us our people. Those are real costs. We need to spend time in interviews. But if we're constantly doing it over and over and over, and people are leaving, and we're not even saying, well, please come back after a few months, once you've rested, we're not even having those conversations. So Anyway, I'm get off my soapbox. We'll turn to question number 3. And Patrick, if you'd like to go first,
Yeah.
what are some of your things for retention?
Sure. Yeah, everything you said touched on this question, so that's great. Yeah, I think I'll just follow up from my last comment on the last question, and encourage folks in health in human resources to think about about retention the same way you think about recruitment. Thinking about your organization from a recruitment perspective can help you look at it from a retention perspective. Recognize what's good already, why people want to be there, and what needs fixing. You need to think about your workplace culture, your reputation, your work-life balance. All of these things are typically more important than money. I mentioned, and Paul mentioned, the signing bonuses. They may be an attraction for folks, but typically we're hearing that they are they're secondary. They're definitely secondary. Some folks might be attracted to those, but they might be attracted to those because, as I said earlier, something else is going on or going wrong in the organization they're in. So in addition, I would say look at every opportunity, as I further to what I said earlier about looking at every opportunity for recruitment, look at every opportunity for retention. So one of the things we're going to talk about, and this is an early plug for our Applichat webinar tomorrow on how to conduct stay interviews, getting engaged with your employees, finding out how things are going for them now. Are they happy? Are they not happy? Are there things that they think need to be fixed? And finding out what you can fix now to address that and keep your staff. We've also done webinars on employee referral programs and the boomerang staff, as I mentioned. And both of those programs engage your existing staff because your employees are referring their friends or colleagues to come to you. They also recruiting back staff from other organizations. It also engages your existing staff by seeing, wow, this is a good place to work. The staff that are coming back are obviously identifying that it's a good place to work. So all of these initiatives are sort of side effects, are ways to engage your existing staff, and they help shine a light on, again, what's working and maybe what's not working. And then finally, if you can staff up, and obviously that's a challenge, that reduces your impact on other staff. And I remember speaking to a talent acquisition manager a few months ago who said, if you can bring me 3 ICU nurses next month, I'm going to be a hero when I walk into the ICU. They're going to be so relieved that they know 3 new nurses are coming in. So that has a big impact to reduce the burden on your existing staff.
Yes, no doubt. Workload is so heavy for everyone right now. Filling those vacancies is important. Suzanne, if you want to come off mute and share your insights.
Thank you. Again, I'm not in the deep weeds and in the real situations with healthcare as my co-speakers here, but I do have some observations that I can share. What are my top 3? How can we improve retention? I guess I spent 10 or 12 years prior to my work now in the world of recognition. So I do know reasons why, in general, people leave organizations. The sad part is in healthcare right now, I alluded to it a little bit earlier, we keep hearing it's burnout, it's burnout, it's burnout. Well, I truly believe that burnout goes away when you have an environment that's a nice place to work, just as Patrick said. Burnout is just a symptom of something else that's bigger and badder. They just put a label on it as burnout. So looking at that and finding out what that stay interview is so critical, and Patrick is putting out something tomorrow on that, so find it and go there. So critical to find the reason, the real reason why people are leaving your organization. I'll come back to that one in a minute. But the second one is if we do know why and we can admit to it, we have to engage the whole organization in the process of the improvement. Raelynn alluded to that. It's not an HR problem. They have the problem, but it's an organizational problem to solve. Everybody has to be involved in solving this problem of high turnover and low retention. And just to comment a little bit, but add a little bit more to what Patrick said. Every leader, supervisor, manager in a healthcare organization has to come to work every day with retention on their mind. They got lots of things to do. They're busy, busy people. But that nurse manager doesn't want to lose 3 nurses this month. So he or she needs to know what to do every day to increase, enhance retention. And I'll put a little plug in there for our moderator, who's doing a fabulous job, by the way, that organizations maybe don't know this, or how to do this, or how to get everybody in the organization thinking retention and doing things every day that focus on retention. You need help with this. And I think an organization, to encompass everything I said, has to put their hand up and admit, okay, we've got a bad organization here. We're not keeping people. Something's wrong. We need help. We need to fix this. So I think those are my 3 top, and I pop in that solution that one of the barriers to talking about retention and even wanting to look at it is you first got to admit that there's something wrong in our organization. We need to fix it.
Excellent. Okay. Thank you, Suzanne. And Paul, I think before you mentioned you have 143, not just 3. So
I added 17 more while we were sitting here. So yeah, I think, you know, my co-panelists' comments are right on. And one of the things that people talk about in my circles is restoring the joy in work. And it's something that I think is elusive and for the most part isn't present, and it hasn't been present in healthcare for a long time. So the question is, how do you give people joy in work? I think that most people who go into healthcare because they believe it matters, it has meaning. Not very many people go into it because they're going to become filthy rich being a nurse or a PSW or whatever. They do it because they believe it matters. So how do we give that back to them? You know, citing Daniel Pink with, you know, autonomy, mastery, and purpose. How do we give people that? Let's get the talk away from money, which is hard to fix, and into other things. So things like make it easier to do your job, like you know, concierge services and daycare services and all that sort of thing. Again, there isn't a direct cash value, it just makes people's lives much better. Opportunity for career advancement. Do we direct our people where they are investing in their careers, but they can feel that that they're growing in their career, and there's an end point, that they're not going to be at the bedside in 35 years. We talk about resilience all the time, and my blood just boils, because what it is it feels like administrators dump crap on people's head and then say, you need to be more resilient. We really need to stop dumping crap on people's heads. And, you know, the sort of the signature issue with that is the electronic health records. This is with physicians. They're terrible. They're all terrible. We don't try to fix them. We just tell people to be more resilient and have a 3rd glass of wine when they're doing their charts at 10 o'clock at night. So it's a backwards way of looking at it from my perspective. And I think we get rid of meaningless work. So, you know, when I was rounding after we installed Cerner at London Health Sciences Centre, you know, just talking to the nurses about how much of this is just sort of garbage clerical work that you don't actually have to do. You're a professional whose job is to, you know, provide clinical care and make high-level clinical decision-making. How much of this is just what we used to call scut, just garbage, meaningless work? And unfortunately, there's way too much of that. If you want to look at big cultural things, and I'll cut this down, but I think that one thing that people need is a connection to the organization and its purpose. And, you know, I used to laugh at mission and vision statements, because it felt like somebody went to a website called www.missionstatement.com, and there were 10 templates, and then they just typed their own organization's name in. They all looked the same. The best organizations, people can walk in and it isn't just a plaque on the wall that they have to look at to even recognize, or it's not a watermark on an email or a tagline on an email, but they actually know what it is and it matters to them. So I think that is really important. what goes with that is visible leadership. Like, leaders have to get their backsides out of their offices, out of the boardrooms, and they need to get around, they need to meet with people and to really truly seek to understand what are the stones in their shoes and what can they do to fix it. So that element of visible leadership, I think, is critically important. The microculture, the culture at the front line, is really critically important. And I went to a session once, and I'm about to say a semi-bad word, but the person at it was talking about how they keep people in the organization and attract people. And she said, it's really simple. We have a no asshole rule. And, you know, that's cutting it down reductio ad absurdum, but mean people, nasty people, people who don't listen to people, they shouldn't be in leadership. And as a matter of fact, I don't want them in my organization. So, you know, sticking to the no asshole rule, and I'm probably going to get kicked off LinkedIn now for saying that, I think it's really important. And it was a woman named Amanda Maza at LHSC, Raelynn, who said, we need to stop just asking experts like me or Suzanne or Patrick or you, Raelynn, and to start asking the people who are leaving and say, why are you leaving and what can we do to keep you? And I know some people do it, but I don't think it's systemic enough. And there's this fatal fundamental flaw that we keep going back to experts coming up with solutions that are crafted on their computers that they bring out to the front line. They say, we have the bestest thing for you ever. And then people go, actually, that wouldn't help me at all. That is absolutely meaningless to it. I've seen it and I've done it, and we need to stop doing it. So that's my list.
Love it. I would love to have you in a brainstorming session where we could work with frontline and leaders to go across the room, across levels, to brainstorm all of these ideas. And you mentioned 137. I agree. There's hundreds of ideas, and it's local, it's individual. So we need to ask people, what matters to you? You know, maybe it is a Tim Hortons card to recognize the employee of the month. Maybe it's your VP making eye contact when he walks down the hall, right? So there's going to be different things that resonate for different people. And I love that there's more and more organizations shining a light on this to say, it's time to fix the culture. We can fix the culture. It's not just, you know, dictated down from above. We can be ingredients in this. And it's going to be, I think, an amazing time coming out of the pandemic for organizations to say, let's get serious about people strategies that have hundreds of ideas that are locally driven, bottom up, and supported from top down. Suzanne, you want to jump in there too?
Well, I was just going to talk about the no asshole rule. Now I'm going to get kicked off LinkedIn with Paul. But I don't, was she the author of the book? Because there was a book written on it. It's in my bookcase behind me. It's an amazing philosophy, and it's so true. Those are the people we want leaving our organization. The ones that are killing, they're great people. And I love it. Thanks for bringing it up, Paul.
I love it too. I have a just say no to a-holes rule in my life, and I think that's so bang on. But I think we also need to remember that person who's being that way might have a boss above him or her that's also part of the problem. And I think we have to, in the context of retention, ask, you know, the nurses who are complaining at the nursing station, okay, what's going on? Why are you so unhappy? Maybe it is a bad supervisor, but maybe that supervisor's manager is where the problem is trickling down. So I think we need to go in with a little bit of forensic analysis, look at those employee engagement surveys that are sitting on the shelf. There's rich data there. And act, listen, tell people you've read them, that there's some problems here, and we're going to start working on them. Paul,
I think that's, yeah, I think you're exactly right, is being careful about scapegoating. You look at a phenomenon and you tend to treat the phenomenon or the symptom instead of the cause of the symptom. And I think that that often that is the case, is there is something systemic that's happening to that person. So I think that's where just culture comes in too, is not leaping to an assumption, making people accountable for their behavior, but also doing a true, sort of, start with no assumptions, question your own assumptions, and work from there in order to be able to find out what's really going on.
Excellent. Patrick, I don't know if you wanted to add in a final thought after the go around there, but we do have one final question.
It's okay, sure. We can move into that question.
Yeah, so I guess we wanted to leave with a little bit of hope, because I believe that hope is where we start and start to create some energy that we can have an impact on this strategy, or sorry, on this crisis. So the last 2 years have been really challenging. So what gives you hope that for the future as we come out of the pandemic? And Paul, I think we were going to start with you on this one.
Yeah, thanks. So I think the thing that I miss the most about being in London and in that role is the people, and not the meetings, not budget, not operating issues and that sort of thing, but getting out to where the work is actually done and hearing the stories of people's commitment to their patients. And I think that has continually grounded me in is that healthcare people go into healthcare because it matters and because they want to make a difference. And I know I said that earlier, but I think that it has selected for a remarkable group of people who, despite all of the bad stuff that has been dumped on them, and systemically so, and hardwired into things over the past number of decades, and then really quite robustly in the last couple of years, is these are really good people who put it out there because they believe that it matters that they put it out there, and because they care about the people that they work that they provide services to. And so they may not care about the organization that they walk into, they may dislike it. As a matter of fact, they frequently do, and understandably so in many cases, but they care about those people that they look after. And I think that that's what gives me hope is we still have those great people in the industry. We still have those great people coming into the industry. And if somehow we can get our act, and I mean, we as sort of system leaders, as organization leaders, as frontline leaders, can get our stuff in order, how could you not be successful in turning that around given the people we have in healthcare? So that's what gives me hope.
Excellent. Like to hear that. Patrick?
Sure. Well, one of the things that I find hopeful is the response to this webinar, and I'm seeing so much discussion in the comments here. And I know Raelynn's planning to get to as many of those comments as we can, but it's really interesting to see all those comments flowing in. Aside from that, I think one thing that gives me some hope is that things seem to be settling a little bit. I mean, the demand is still intense. There's still an immense amount of movement within the healthcare industry, but it feels like it's settled down a little bit through the worst of the COVID crisis. Having said that, I remember a healthcare organization tell me about a year ago that, oh yeah, it's much better now. We're past it. It's going to be better now. We don't really need much to worry too much about this. And then, of course, the lid came off again. But it does feel like it's a little bit calmer than before. We also see that more nurses are looking for permanent placements in our world of focusing on nurse recruitment. So more nurses are looking for permanent placements as opposed to so many turning towards the travel postings with the big dollars behind them. So that's really optimistic for healthcare organizations. And we're also seeing, you mentioned earlier, Raelynn, the travel nurse fees, but we're hearing that those are coming down a little bit, although it depends on your location and your specific demographics. I talked to someone the other day in a more remote location who really felt that they were getting gouged with an agency who, as the fees were higher than ever more recently. So there's obviously a gray area on that one. And then the other thing that gives me hope is that I think we've all learned a great deal in the last couple of years. We've all been forced to become more innovative. How many of us were doing Zoom calls and video webinars, just as one example. But as I said earlier, healthcare organizations are really trying to look at everything under the sun to recruit and moving more towards retention. So I think everyone's been forced to become more innovative, and based on what we've learned in the last couple of years.
Excellent. That does give me hope. Suzanne, to you.
Sure. Just to bounce off Paul and Patrick, the pandemic, COVID, has lots of silver linings, and we have done a lot of changes because of it. And as one healthcare professional said to both Raelynn and I, COVID has just exacerbated the problem that we've been looking at for many, many, many years. But maybe it's brought it to the bubbling point where now we're going to start to reflect and look back in and do those the why question, get that answered as to why we're losing so many people. And just to give a very current experience I had yesterday, and I'll be quick on this. I don't know if any of you are familiar with Dr. Justin Maloney, who was an emergency doctor in Ottawa for 40 years. but he was the instigator to get 911 into Ottawa when it was an experiment, I think in Hamilton and London, way back. He developed the training program across Canada to train teenagers on how to save lives, doing CPR, just many, many impacts to our healthcare system. But the people that spoke at his ceremony or celebration of life, it was yesterday, they had tears in their eyes talking about how he would take somebody new into the ER, new physician, a new nurse, a new ICU nurse, and make them be better at what they did every day. And that's the biggie that they're remembering about him as a person that they worked with. So it really punches at home that, all these, great credentials he had and awards he won and all this great stuff he did. He was very humble about it all. But they all remembered that he made us be better at what we did every day. So we got to start talking about this stuff more and more.
That's an amazing insight that you share, and it kind of reminds me of all the work that I've done through my career. It's those moments where I had a leader who was a little bit empathetic, or who gave me the benefit of the doubt, or created some room if I had a challenge in my life. Those are the moments that I remember in my career, and those are the leaders that I admire and I treat as mentors. So I think there is an opportunity for us to foster that kind of leadership that all three of you have talked about, and to create those amazing cultures where people love to work. One comment in the chat, Jana Bartley, dear colleague of ours and a co-board member of the Resilient Kids Canada group there, she talks about there being a need for huge spending on flipping the tide on cultures and healthcare teams and decision makers. I think that you mean DMs, or direct managers, are the sculptors of the healthcare system, and they need to be developed before teams adapt. So I completely agree with you. A lot of people, they start out as a nurse or physiotherapist or whatever, and they're put into a position of leadership, and we don't necessarily take the time to develop some of these skills that we need to. So one thing that gives me hope is that we've designed training to get out there and help be part of the solution. We've got a little slide that we can put up. If people are interested, they can reach out and message either Suzanne or I about this one-day people strategy. The next slide, if you don't mind, Patrick. I've also posted something on LinkedIn. June 14th, let's not wait till after the summer. Let's get busy, people. We need to design people strategies to talk about all these things that Paul mentioned and Patrick mentioned. And we are here to help and build capabilities. So we've designed low-cost, high-impact training that you can come with your team and design a people strategy from start to finish. Talk the ROI to your finance team, your C-suite, and some position or some change in place so we can save our workforce. And Patrick, I love that you're having the state conversation tomorrow at 1 o'clock. Happy to be joining you for that. That's, I think, your next slide, to help us, coach leaders on how to have these important conversations. Don't just let them quit. I had lunch with a colleague of mine who said his wife just, after a long career as a mammography technician, just quit, and nobody asked her, why? Will you come back after you've had a break? And she wants to work at a hardware store. So, we've got a huge talent pool of talented, credentialed people that we need to attract back. And the only way we're going to attract them back is if we change the culture.
Yeah, and also I'll touch on this. Thanks, Raelynn, in advance for joining us tomorrow to talk about stay interviews. So obviously, a lot of organizations use exit interviews. So we're finding out why people are leaving an organization, but we're not always understanding why people might want to leave in advance, or why they want to stay. So this is something we're going to talk about tomorrow with Raelynn, and also with Molly Weaver, who is the founder of Sunflower Talent Strategies. She has many years of experience in talent acquisition at Children's Mercy Hospital in Kansas City, Missouri. So we're looking forward to a really good conversation tomorrow. I'm going to put the link in the chat, and that's to the LinkedIn event page. So you can follow that link or find us at Applichat Healthcare and come sign up for our event tomorrow. That's at, as Raelynn said, at 1 Eastern time tomorrow. So we're looking forward to that. Thanks for the chance to make that plug and for joining us tomorrow, Raelynn.
I'm going to take a look at some of the comments in the chat, and I think we could encourage people to just continue the dialogue on LinkedIn, because I know there's many comments here that Paul and Suzanne and Patrick, you'd like to read as well, and I believe they're on the LinkedIn stream. So maybe if you want to stop sharing, and Paul and Suzanne, if you want to jump back in with some final comments, I'll take a look through the chat here.
Sure. I'll just speak to the stay interview session tomorrow, which I'm going to attend. I'm excited about it.
Great.
And our workshop on June 14th, I said to our group, or maybe just to Raelynn, maybe, I said, this is a conversation. Well, let's get real about this crisis. But as Raelynn said in the beginning, we can't just talk about this. We've got to make some steps. We've got to take an initiative. We've got to do something to start stopping that boat from leaking, as Raelynn will speak to. So we had to offer something to help you do something to make the first step. Maybe this gets you a little bit of skill and competency to take it to your organization from the stay interviews or our workshop on retention, people strategies, and how to show your executives and your funders that if you invest in retention and make it an investment, not a cost, there is a positive ROI once we start improving it. So those are really neat things to take away from this, that you're just not having a conversation. You've got some things to put your hooks into.
Important messages, and the reason HR folks aren't thinking about these is part of it is cultural. That's how HR folks are trained, and that's where the focus is not on that in the current work environment. And also, it's, as Raelynn mentioned, the silos within organizations. It's hard for HR people to get an understanding of the dollars and cents within an organization. So culturally, within the organization at all, there's work that can be done beyond the HR folks.
One thing I just want, maybe Paul, I'd like you to jump in here, because we had a conversation about the cost of replacement. And this is something we offer in our training when you try to calculate the return on investment. What is this costing you, this turnover? And if we say that a nurse is $75,000 to replace, you had 400 nurses in London Health Science Center. So I just want to go back to one of the, sorry, 4,000. Okay, 4,000 times 75. So, like I calculated, in my case study, $22.5 million every year being lost to churn that wasn't even showing up anywhere. No one knew. But if the ministry gave you $22 million, what would you do? Yeah. Bet you'd increase wages. Bet you'd have some leadership training. And June Porter, thank you for sharing your first name. One of her first comments in the chat was, our local region feels the crisis with recruitment of nurses, PSWs, family physicians is due to a lack of affordable housing. So that's a big problem. And I read something on LinkedIn, I think the CCHL put it out. Let's fix racism in our communities. Mm-hmm. Holy cow. Okay, so these are big things to fix. Yeah. But people will stay if they have a leader who is kind, makes eye contact, says thank you. Maybe if we keep some of these staff, we save $22.5 million, we can make a pitch to government to do something about housing or childcare or some of the bigger challenges. Yeah. Suzanne, you want to jump in? I think Paul.
Yeah, I'm going to go back to a comment Paul made to reflect on. It's June, her comment.
June, yeah.
Said her local, I don't know, feels that is the reason. Let's really push that. Feels the crisis is affordable housing. Well, let's find out if that's true. What the local region feels may not be what the people, actually, the frontline people are saying or believe or live. So I push that, as I do with everything. Push it to get the real why. Don't just bank on somebody's feeling that's the reason. Get some data around it. Yeah.
Yes, and if they are told that absolutely it's an issue, or driving to work, or all these other the cost of gas for PSWs is an issue. Mm-hmm. We need to get finance involved. Maybe there is an opportunity to say, okay, we're going to save some money over here, and we can have an incentive of some sort of support to help our leaders or our frontline staff who are feeling the increased pressure. Paul, do you want to jump in?
Yeah, on that last piece, here in the United States, health systems are actually subsidizing housing or buying housing and then providing it at affordable sort of rent for people that they bring in, not possible in Canada. But if you think about it, what is possible in Canada, because it's all a single tax dollar, is the ability to partner between healthcare provider organizations, whoever they would be, or just the community in general, that healthcare provider community, and municipalities, in order to be able to do this kind of stuff, to build sort of affordable housing and that sort of thing.
Mm-hmm.
So we talk a lot about the barriers that we have in Canada, but we also have some amazing affordances that I think that aren't leveraged. And the mayor of London, when I was there, was incredibly supportive of London Health Sciences Centre, and was always asking, what can we do as a municipality, as a city, in order to be able to support the hospital? So I think taking our courage in hand and a good solid business case to places like that is good. I just want to, sort of my final comment again is, hospitals everywhere, whether it's in Canada or the United States or elsewhere in the world, are always scratching and scraping to try to make ends meet. And most recently, my experience being in Ontario, London Health Sciences Centre, 1% of the budget is $12 million. And we would just about do anything to get that $12 million. And we were scratching and scraping and everything like this. If you start to take the numbers of what it costs to replace people, or to not have people, to use agencies and all that sort of thing, there are a lot of $12 million in those things. There are a lot of percent of the budget. And it's somewhat shocking that we spend so little time and so little effort on how do we make people happy, how do we give them joy in their work, where they want to stay at London Health Sciences Centre, live in London, enjoy the municipality, enjoy the community, and that sort of thing. And it just behooves us to do that, because nobody wants to pay more taxes. I think that's a fair statement. So just asking for more money, how are we best using the money that we are getting? And I think we need to do a far better job of that. And this is a strategy that's so obvious, and yet it's just consistently overlooked.
I'll just touch really quickly on the housing comment. Further to what Paul said, I spoke to a healthcare organization in Ontario yesterday that they identified housing as a big barrier, and they are trying to do what they can. They've rented a couple of apartments that they're helping people get settled in, and they are providing a housing subsidy for the first year for nurses. So we are seeing some innovative activities in Canada too in terms of the housing issue, but huge challenging problem in many communities.
Well, what I think is interesting, we've got solutions being crafted at all levels. Maybe housing is a government-wide problem. And when we look at Nova Scotia and our friend Janet Davidson leading some excellent work out there, we keep looking, okay, is that recruitment or is that retention? And Janet, if you're listening, we want you to focus a little bit more on retention. But one of their things was affordable housing to attract people to some of those rural communities. And Paul, I know that your organization was a leader in eShift as a workforce solution to keep nurses who are so experienced and excellent credentials working a little bit longer into their career, not at the bedside, but having technicians, travel and be on the road. So that was an innovative approach to solving a workforce challenge with technology. So I think we have opportunity now to rethink some of these things. I see you've come off mute.
Yeah, and I think that's a point maybe that we haven't emphasized enough too, is we also can't keep doing exactly the same thing that we've always done in terms of how we provide care. And healthcare is not particularly innovative when it comes to that particular thing. A lot of the ways that we provide care are solidly founded on models from the 50s and 60s. And so looking at how we provide care, that's a great example, Raelynn, of technology-enabled care, and everybody wins. The patient gets high quality care in their own home. The hospital doesn't have patients in it that they would have had that not been there. Nurses are able to extend their careers in a different sort of setting. I mean, we need to kind of get out of the starting blocks on some of this workflow care model redesign, because regardless of how well we retain people, how well we recruit people, how well we educate people, there still aren't enough people. So we need to do things differently and better.
Mm-hmm.
Love it. And I think, hopefully coming from crisis, there's a silver lining here. that we can rethink how we do things. And, obviously we're talking about leadership skills and communication, and, HR talking like finance and crossing silos. That's the low hanging fruit. There are some more complicated solutions, obviously, but if you go across the organization, everyone, I think it was Eric, somebody on the chat said, you talk to the front line, they'll tell you the pebbles in their shoes. There's so many solutions out there. So any final comments? I know we're coming up on the close, and I think someone asked, the recording will be available on LinkedIn and on YouTube, brand new YouTube channel. But let's continue to build a community of support through this community. I think there's so many great ideas out there already on the chat, and stay connected with all of us on LinkedIn. I believe we do want to support a bit of a community of practice here as we go forward in finding solutions. And if you're interested in being a speaker on this crazy panel we've created, reach out to all of us, as we'd love to hear some different perspectives and insights on this. Any final thoughts from any of the panel?
We got it.
Not really. Thanks, everybody. And yeah, hang with us. We need more minds, more voices, more thoughts on all of this.
Thanks for hosting this, Raelynn and Suzanne, as well.
Yeah.
Well, the other point on that is to stay with us and, continue the conversation, but take some action. We'd love to hear, Raelynn and I for sure, would love to hear what anybody's doing in an organization around retention. Like what initiatives are happening in your organizations that are working towards retention. We'd love to hear that.
And I just see Renata threw in a comment, national licensure, not collecting membership. Oh, are we over our time? I think we're over our time.
We are over our time, but we're still going.
Okay, terrific. Well, thank you, everyone. Really appreciated hearing your insights and joining us for this wonderful conversation. And let's stay in touch.
Great. Thank you.
Thanks.
Great. Thanks, everybody.